بسم الله الرحمن الرحيم. رب اشرح لي صدري ويسر لي أمري واحلل عقدة من لساني يفقه قولي. During this presentation, we will deal with normal and abnormal puberty. Puberty is a physiological phase lasting 2 to 5 years, during which the genital organs maturate. It represents the first phase of adolescence. Adolescence is the period of life during which physical, sexual, and psychological development are completed. It is the phase between childhood and adulthood. Manifestations of puberty in female include menarche, appearance of secondary sex characters, development of breast, appearance of pubic and axillary hair, development of characteristic body odor, physical development or growth spurt, and psychological changes. The first sign of pubertal development is breast growth or thelarche, followed by appearance of pubic hair or pubarch and axillary hair. Finally, menarche occurs. Adrenarche means increased activity of the suprarenal cortex at puberty, with increased production of adrenal androgen, resulting in appearance of pubic and axillary hair. The mean interval between breast budding and menarche is 2.5 plus or minus 1 year. Definite signs of puberty usually start by the age of 9 or 10 years and completed by the age of 11 to 13 years. Stages of puberty are growth spurt, thelarche, adrenarche, and finally menarche. Tanner's classification and staging is a system based on the orderly progressive development of breasts and pubic hair in females. Breast is the mirror of a gynecologist. It indicates the prevailing endogenous sex steroid, either androgen or estrogen. Tanner staging of breast development include Stage 1, Stage 2, Stage 3, Stage 4, and finally Stage 5. Factors affecting the onset of puberty may be genetic factor, nutritional factor, general health, exposure to light, geographic location, and psychological factor. The concordance of the age of menarche in mother-daughter pairs and between sisters and in some ethnic population illustrates the importance of genetic factors. Blind girls undergo menarche earlier than sighted ones, suggesting some influence of light. One of the more controversial theories centers on the role of total body weight and body composition on the age of menarche. It is found that a girl must reach a critical body weight estimated by 47.8 kg before menarche can occur. Body fat must increase to 23.5% from the typical 16% of the pre-pubertal state. Hormonal changes during puberty affect the following hormone. Growth hormone and gonadotropin secretion increase at the onset of puberty. Girls have a higher basal level of growth hormone throughout puberty, reaching its maximal level around the time of menarche and decreasing later on. Growth hormone secretion is highly pulsatile, with most pulses occurring during sleep. Sex steroids increase its pulse amplitude rather than altering pulse frequency. A reduction in insulin growth factor binding proteins leads to an increase in insulin growth factor stimulating somatic growth. Genital organ changes during puberty. Mons veneris, labia majora and minora increase in size. Vaginal length increase with appearance of rugae. Vaginal epithelia becomes thick, stratified squamous, containing glycogen. Vaginal pH becomes acidic. Uterus enlarges in size. Uterine cervix ratio is 2:1. The ovaries increase in size, almond shaped, containing 300,000 primary follicles at menarche. Abnormalities of puberty include aberrations of puberty, growth problem during adolescence as short or tall stature or marked obesity, and menstrual disorders at puberty. Aberrations of puberty include delayed or interrupted puberty, asynchronous pubertal development, precocious puberty, and heterosexual puberty. Precocious puberty may be iso or heterosexual. Isosexual puberty may be complete or incomplete. Complete isosexual puberty may be central, peripheral, or combined. Incomplete isosexual puberty may be in the form of premature thelarche or premature adrenarche. Precocious puberty is premature initiation of sexual development and menstruation before the age of 9 years. It may be isosexual with normal and feminine constitution, or heterosexual in which the girl looks virilized. Isosexual precocious puberty may be complete or incomplete. The complete variety may be central or true, peripheral or false, and the incomplete variety there may be isolated thelarche and adrenarche. In central or true variety, ovulation and sex hormone production are due to early activation of the hypothalamo-pituitary ovarian axis. If peripheral or false complete precocious puberty is due to hormone production from the ovary or exogenous intake. Heterosexual puberty means virilization in girls. As regards the causes, the most common cause of isosexual precocious puberty is constitutional cases. Constitutional causes is the commonest cause of isosexual complete precocious puberty. Other causes include higher center or organic brain disease. In peripheral or false complete isosexual precocious puberty, the sex steroids are arising from the ovary or exogenous intake, like feminizing ovarian or adrenal tumor, primary hypothyroidism, macunal bright, ectopic gonadotropin production, and iatrogenic or exogenous drugs. incomplete isosexual precocious puberty, 50% of patients have organic brain disease. The heterosexual precocious puberty is caused by congenital adrenal hyperplasia, adrenogenic ovarian tumor, adrenal tumors, and exogenous androgens. Manifestations of excess androgen in female are defeminization, masculinization, hirsutism, and virilization. Clinical presentation of congenital adrenal hyperplasia differs according to the age. At birth, it may be in the form of ambiguous genitalia. Late in childhood, it appears as heterosexual precocious puberty. In adolescence or early adulthood, it presents by defeminization, oligomenorrhea, and or infertility. McCune-Albright syndrome is a disease found more frequently in girls. It consists of a triad of precocious puberty, cystic changes in bones, café au lait patches of the skin. The cause of precocious puberty is autonomous production of estrogen by the ovaries. FSH and LH levels are low. Treated by testosterone oral tablets, which inhibit ovarian steroidogenesis. This slide demonstrates café au lait patches and cystic changes of bones in McCune-Albright syndrome. Diagnosis of precocious puberty. From history, you must exclude a iatrogenic source of estrogen or androgen. You must differentiate between isosexual and heterosexual precocious puberty. By physical examination, you can diagnose McCune-Albright syndrome, and you can exclude organic lesions of the brain by neurologic and ophthalmologic examinations. Special investigations are done according to the history and the clinical findings. X-ray examination of the hand and wrist to determine bone age is needed in cases of precocious puberty. Estrogen stimulates growth of bone but causes early fusion of the epiphysis, so the child is taller than her peers during childhood, but she is shorter during adult life. Hypothyroidism causes retardation of bone age, and it is the only condition of precocious puberty in which bone age is retarded. Hormonal assay for FSH, LH, prolactin, estradiol, testosterone, 17-hydroxyprogesterone, TSH, and non-gestational HCG. Ultrasonography to diagnose ovarian or adrenal tumor. Imaging by CT or MRI to diagnose organic lesions of the brain and the adrenal tumors. Idiopathic precocious puberty is diagnosed by exclusion. To treat a case of precocious puberty, we are in need to arrest maturation until normal pubertal age is reached. This will maximize adult height. Also, we need to attenuate and diminish established precocious characteristics. Finally, try to avoid sexual abuse to reduce emotional and social problems. Treatment of the cause is the essential line of treatment of most cases of precocious puberty. For example, removal of ovarian and adrenal tumors, thyroxine for hypothyroidism, and in incomplete forms, we don't require treatment if estrogen production is not increased. 50% of patients have organic brain disease which can be managed accordingly. Idiopathic type of precocious puberty is treated by explanation, reassurance, and giving one of the following drugs, which inhibit the secretion of gonadotrophins. These drugs are gonadotrophin-releasing hormone analog, medroxyprogesterone acetate, Provera or Depo-Provera, danazol, and cyprotrone acetate or Androcure. Treatment in idiopathic type is given till the age of 12 years, which is the mean age of pubertal development. Delayed puberty is defined as number 1, absence of breast development by the age of 14 years. Number 2, if more than 3 years elapsed between the onset of CLARC and MENARC. Delayed sexual maturation or primary amenorrhea is the absence of menses by the age of 16 years in presence of good secondary sex characters. In other words, delayed puberty may be delayed onset or delayed progression. Delayed onset if breast bulb doesn't appear till the age of 13 years, or menarche doesn't occur till the age of 16 years. Delayed progression means that menarche doesn't occur within 3 to 5 years after breast bulb. Causes of delayed puberty are eogonadotrophic delayed puberty, hypergonadotrophic hypogonadism, hypogonadotrophic hypogonadism. Eogonadotrophic delayed puberty is called constitutional or familial, in which the cause is not defined. There is normal progression of the stages of puberty, but initiation is simply delayed. In hypergonadotrophic hypogonadism, ovaries are not functioning and not responding to gonadotrophins. Level of gonadotrophins are high. Examples: gonadal dysgenesis, Turner syndrome, premature ovarian failure, and ovarian failure due to radiotherapy or chemotherapy. Hypogonadotrophic hypogonadism, in which the ovary is normal but signal from the hypothalamus is abnormal. Examples: organic brain disease, Twitter tumors, Kallman syndrome, psychological stress, exercises, and anorexia nervosa. Diagnosis of delayed puberty is done by history taking, examination, and investigation. You may find positive family history, history of systemic chronic debilitating disease, history of endocrinal disturbances, symptomatology of space occupying lesion in the ovary, adrenal, pituitary, or hypothalamus, periodic or cyclic pain with positive secondary sex characters is suggestive for imperfect hymen. During examination, some body measurements must be done. body weight, height, body proportions, upper over lower segment ratio, arm span over height ratio. Tunnel staging for breast, pubic and axillary hair must be done. Look for signs of Turner syndrome, Mullerian agenesis, and imperforate hymen. Neurological evaluation for smell in Kalman syndrome, visual field, and other cranial nerve lesions. Special investigations are needed for diagnosis of delayed puberty. FSH and LH assay to differentiate between different lesions. Progesterone assay, 17-hydroxyprogesterone assay, chromosomal study if there is short stature or hypogonadotrophic type, radiological bone aging study, and radiologic study of for pituitary adenoma. Treatment of delayed puberty is essentially treatment of the cause. Constitutional delayed puberty, no treatment apart from reassurance. Patient with Y chromosome cell line, gonadectomy and hormone replacement therapy is needed. Thank you for your attention. All good wishes and good luck.